And here we are one more time in our week, in our quest to improve our health, to reduce our blood sugars, to get off of medication, to become non-diabetic. Hey, that's what we're doing. That's what we're talking about. Hey, this is Dr. Dwain Woode. That's Wood with an E. The E stands for endocrinology. Here I educate, I empower, and I encourage you to take charge of your health and your life, avoid complications, go to the next level. We're creating the life we've always wanted, and we are living, that's right, we're living limitless lives. If you're new to me, go ahead and put new in the comments because I'd love to welcome you with a hand clap and some music. And let you know that I am excited that you are here. If you have questions as we go through our episode tonight, go ahead and drop those in the comments. Make sure you put a Q in front of the question, or the Q in front of it, so we know that that is a question that we need to get to as we move through our space tonight. We've got a lot of good things that we're going to be taking a look at here in just a minute. I've got my meters that we're going to take a look at. I've got my reports that we're going to take a look at. And of course, you are here because we're going to talk about what's been going on with me and my labs. I had my physician visit here just a little while ago, a couple weeks ago, as I mentioned. I'm going to take a look to see what's been going on with my blood work, so you can see what's been happening. But like I said, I've got my monitors. Let me go ahead and pull that. I've got my meters over here. I got my Contour and my Keto Mojo, and of course right down below me, that is my Dexcom Clarity Report, which we will look at here in just a minute. And I am right now, at this moment, a little over 33 hours. Let me give a hand clap and some music. That's right, 33 hours into this week's fast. And many of you that are out there, you've been fasting with us. Today was the end, as we did our check-in earlier today, was the end of our 24 hours. So kudos to those of you who are out there who fasted for yesterday into today. Those of you who started your fast today and heading into tomorrow, come on, we're doing it together. And of course, those who are starting tomorrow into Friday, excited for that as well. As you know, we do a 72-hour fast once a week. And I guess let me just say we do a fast once a week, whether that's 72, 48, 36, or a different type of fast. That's a whole nother issue, and we're talking about playing our own game as we've been going through this space. So I see some of you out there will come out and say hello to you in just a minute. But welcome, whatever platform you're on, whether that's LinkedIn or Twitch or Facebook, and of course here on YouTube. I welcome you. Whatever area you're from, if you're overseas, if you're in the US, we're excited to have you along with us. I see people that are out there. I see somebody from Nebraska, from Atlanta, from Atlanta and Georgia, people from Tennessee, and of course Ohio. We've got some folks from the Netherlands. We got some folks from Korea who normally watch. So wherever you're from, go ahead and drop that in the chat, in the comment, because we want to say hello to you as well. So 33 hours into this week's fast, we're going to take a look at my numbers so we can see what's been happening in my space. In fact, my monitor has been going off today for at least the last part of the day. So why don't we hop over and let's take a look at that right now. Let me go ahead and pull up this is my Freestyle Libre that we're taking a look at here. And this is, you'll see my number right there. That's what my blood sugar is right now. At this moment, it's 59. And if you scroll down to about here, this is what I was just telling you, that my monitor has, for most of the afternoon, been saying, hey, you are low. And so you'll see that squiggly line that's there. The first part of that line is white, and that means that it's above 70, and then it went below 70, and that's why you see that it's red right about there. Okay, I can go and let's take a look at some of the reports that this thing will give me. My time in range, and if we look right in the middle there, for the last 7 days, I've been in range 94% of the time, with 6% of those, or 6% of the total, being below 100. or below 70, I guess I should say. And so if you combine those two numbers, that's where you get your 100%. If I go to 90 days, once again, looking right here, you'll see that I'm in range 87% with 13% of the total being low. And so if you combine the 87 with the 13, that gives you 100 once again. And then getting out of this report, going to average glucose. What I like about this is it breaks it down into the different times. And so depending on the time of the day, you'll see there that the average for the entire day is right on this line, is 92. And then down throughout the day, it's been in the 80s and 90s as I move throughout the day. If I go to the 90-day view, and that was the 7-day view, you'll see there that we're in the 80s and 90s. So good numbers. Let's go ahead and we're going to pull up my Dexcom and get rid of that. And here is my blood sugar right now. We're going to put that in the 24-hour. So that's my blood sugar right now, 77. And then scrolling down, just like we did in the Libre, you'll see that my blood sugar is, and actually what I didn't do in the Libre is I didn't put my finger so you could see what the actual numbers are. So 106, 100. So the upper 90s to low 100s is where it's been. And then flip below 100 and then continued there for the rest of the day down to where we are right now. If you've not done so yet, go back, and if you go to this week's videos, you'll see the video that I did yesterday where I started the fast. You see what my blood sugar was, and you saw what I ate is what I want you to see. I want to see what I ate, and then you can track the blood sugars to see what's been going on with the blood sugars since I ate. Okay, and then let's go ahead and I'm going to grab my monitors, and here's my Contour and my Keto Mojo. So let's go into my container. We're going to get a blue for ketones for the Keto Mojo and a brown strip for blood sugar. And of course I need a lancet. Get that back, and then I need a strip also for the Contour. So let's get that out. Boom, boom, boom. All right, and so let's get this one in here. I'm gonna go ahead and open up this strip, and this is the one for blood sugar. Get that in. And since I'm here, as you guys know, I don't like to stick myself again, so we're gonna go ahead and open up the one for, boom, there we are. This is the ketone strip. So what do you think my ketones are going to be, by the way? Let me put this right here. So at 33 hours, here's my Lancet. And I don't usually use the lancing device. We just find a finger and ow. And it's okay. So that's a pretty brisk drop. Let's get that in. Get that in. And get those going. And so here is my, so 66 for the Contour, 74 for the Keto Mojo, and then of course right here you'll see 79 is what my Dexcom says. So let's get this one out and get the one for the ketones in. And let's make sure we still have a good drop of blood. All right, I think that will still work. Okay, so let's get that going. All right, and 6, 5, 4, 3, 2, and 1. And 1.1, what my ketones are. So let me go ahead and I'm going to pull up the Keto Mojo app, and let's go ahead and pull that in. We'll have to get that to sync. And you get to see that as it's happening. Let's say try again. And it'll pull those over, because I want to talk to you about the ketones. So remember, ketones that are less than 0.5 considered normal, 0.5 to 1.5 considered nutritional ketosis, and of course above 1.5 considered therapeutic ketosis. And so based on what we saw there a minute ago for me, I'm in that nutritional ketosis area. So when you are doing a ketogenic diet, when you're doing a fasting mimicking diet, when you are fasting and you're talking about burning calories, burning fat, what you want is you want those ketones to be at least 0.5 or higher, because that is putting you in the space where your body is now having to go to fat to get energy. And we'll talk about that here in just a minute. Briefly, when we do our complete review of fasting on Friday, right, we'll go into a lot more detail on that. So come join us. There are shows that we've done in the past on fasting and explain those concepts as well. So we'll kind of wait for that to pop up. Well, actually, let's stay there. Let's see if it gives us what we need. So we want those blood sugars to be in or the ketones to be 0.5 or higher. That means that we're burning sugar. Let's go ahead, and while that's coming up, I'm going to hop over and let's take a look at my monitor or my report. And here's my Dexcom Clarity report. This is a 14-day average with my average blood sugar being 119 for the last 14 days. I'm in target 98% of the time. My glucose management indicator would be a 6.1. That means if I were to get an A1C right now, I would anticipate that it would be a 6.1. Okay, let's break off and let's go back to, because this looks like it's done. And let's say finish. All right. So what we're looking at is we're looking at these three numbers right here. So the big one in the middle, which is what my glucoketo index is, or glucose ketone index. And then down here, you'll see my glucose, which was 74, and then my ketones is 1.1. So when we are looking at these three numbers, we want the GKI to be as low as possible. We want the glucose to be low, and then we want the ketones to be high. So that tells me, and so if we look at blood sugar, I'm going to do something here real quickly. Let me move over to the Libre, and let's take a look at what my number. Okay, so the Libre is right now saying that my glucose is 59, or my blood sugar is 59. So if my blood sugar is low, and as you know, the Dexcom tends to be about 20 points or so higher. So if my blood sugar is low, then where's my body getting energy from at this point to run? And that takes us back here. In order for my body to run, if my blood sugar is actually low, then it would have to be burning ketones. So when I see ketones that are elevated in light of a low blood sugar, I know the only place that my body is getting energy from at that point is it has to be burning ketones to produce burning fat to produce ketones. And that translates into another app that we're going to look at here. It translates into this one, because this is the app that I use to track my weight. Going back to, let's go back here, looking at where my weight came from. So here we are at 260 pounds, down to where we are currently today. I just weighed just a little while ago at 184. And so in order for those pounds to go away, and we've been in this space fasting, in order for those pounds to go away, to burn those pounds, to get rid of the fat that's there, that's stored in those adipocytes, which is the fat cells, then I have to force the body to go into the cells and pull the fat out. Well, how do I do that? Well, first of all, the body's not going to do that as long as there's energy that's available. And the energy that's available comes from the food that we're eating. And if my blood sugar is elevated, then the body does not have to go anywhere to get energy, because it's constantly being fed by the energy in the food that we're eating. So one of the benefits of fasting is that, remember those pillars? We decrease insulin, we suppress the appetite, reduce sugar. Well, if I'm reducing sugar, then the body has to, at some point, when the blood sugar gets low enough, it has to go find sugar somewhere else. The first place it goes to the liver. Once the stuff in the liver is used up, then it goes to the fat cells. Okay? So just wanted to make that point there. So going back now to this guy, my glucose-keto index, you're looking at that number. You say, wait a minute, if I divide glucose by ketones, 74 by 1.1, I don't get 3.7. Well, what you've got to do is you've got to convert that. And let's see, do I have my calculator up? No, I don't have it up. But we're going to go ahead and we're going to pull that up here. Let's do this. Pull my calculator up. Let's get rid of some of these other apps. And let's do that. Okay, so here's my calculator. So if I take 74, I've got to convert it into international units. So I divide that by 18. And that gives me 4.1. And then I divide that by a 1.1. And that's where I get the 3.7 that you saw over here. Okay, so if you have a monitor that does that for you, great. If not, there are monitors on the internet that you can go to, and you plug in what your blood sugar is, plug in what your ketone is, and it tells you what that GKI is. Let's see, GKI calculator. Let's grab this one. Let's see. Cancel. So yeah, so you can go and here's one. Let's do this one real quickly. So this is the one that goes with the monitor that I have. So my glucose was 74 and my ketones 1.1. And when I calculate that, I get that 3.7. Okay, so if you have a calculator or if you have a monitor that does it for you, great. But it's not a difficult calculation, but it is this calculation that you have to do. So now let's go ahead and let's get back over here. We were walking through my monitor or my report, 14-day GMI, so different one now. So what my estimated A1C would be, right? It's a surrogate for that. And let's go ahead and change that to 90 days. And we'll see that for 90 days now, my average blood sugar 118. I usually tell people I want them to be between 100 and 120. I'm in target 98% of the time. My GMI would be 6.1. So if I were to get an A1C based on these numbers, I would expect it to be 6.1. Now let's go ahead and let's take a look at what my blood sugars have been. And I want to go back specifically and talk about what happened since yesterday. So we started our fast right about here. So blood sugar of 95. And if you've not already seen what I ate as my last meal, go back and watch that. And so here we are. So we started here and then we ate that meal. And let's watch the blood sugar track, see what happened to it. So it climbed. So we started at 95. Looks like the highest it got up to right there was 113. 113. And then right around midnight last night got up to 120. And then started coming back down over the course of the morning. And right in here is where I usually would get that toothpaste effect. Not as profound as it usually is. And so up to 115. And then for the rest of the day into the 80s and 90s down to where we are right now. Okay? Awesome. So that's what's happened now at 33 hours with blood sugars between, if you go to the Libre 59 up to 74, which if I go with the Dexcom, with blood sugars right now between that range with a ketone levels of 1.1. So right now within that space, remember, it takes about 24 to 36 hours for my glycogen in my liver to go away, and my body now is in full ketosis. So I love that. Now, let's go ahead and we're going to say hello to some of our community members, and then we'll get into our discussion. So let's see. I see some of you are out there. I see Pam. So Pam, what is? Oh, that's not the one I wanted. Let's get rid of that. There we go. So Pam, hello Pam. How are you? Glad that you are here hanging out with us. And then I see, and Pam is saying hello. Bowie saying hi. Cornelia saying hello. Jennifer saying howdy all. Steve said hey ladies. And Jeff, what's up Jeff? What's going on? Haven't seen you in a minute, man. So with your FL3 Plus, do you use the custom time in range for a tight time in range, 50 to 140? So very good question. So I leave my monitors where they are. I had adjusted it so that we went from 70 to 140. I mean, kind of what you're saying. But I'm attuned to it enough now that it doesn't even though my range says 70 to 180, I don't stay in that range. I don't try to stay in that range. I've done it I do it in my head and know where I need to be. I do have, actually no, let me change that, because I do have it alarm at 150. So yes, so I did make a change because I want to know when it goes above 150. And so if you're out there, what Jeff is saying is when in your monitor you can actually go in and let's see, you can actually go in and change the settings. Let's see, alarms. Here we are. Let me pop back over there. So you can actually go into the monitors. These are the CGMs, or you can actually do this on regular finger stick monitors as well, and you could tell it where you wanted to put the alarms. Okay, you could tell it where you wanted to put the alarms. And so here, I mean, high blood sugar is set right now at 250 for this. Let me go back and see, because this one is the new app. Let's see what my Dexcom is set to. Alerts. All right, so here it is. So I guess I didn't change this one either. So yeah, so you can go in and you can actually tell it where you want those alerts to be, so that it keeps you aware. But as I was saying, Jeff, I've done it and I do it often enough that I look at the monitor and I don't necessarily need the graph or the chart to kind of keep me in that space. But very good question. Let's see. And Pam is saying hi to Steve. And Steve said, do you have problems with your sensor being wrong from time to time? Steve, that is like the thing, right? So there is all the monitors, all the sensors. I remember when they first came out, they would come and they would tell you about how accurate their sensor is and how much it's called MARD, mean average, MARD, mean average something. I'm blanking on the word. And they would tell you how close it is to what the actual line should be. And so the Dexcom right now checks blood sugars every 5 minutes. The Libre checks blood sugars every minute. So for the Dexcom, you're getting much less numbers per time compared to the Libre. And so there's some thought that because you're getting more numbers, it's kind of like being in a class, right? So if you have a class, if you're doing well, you want less exams. But if you're not doing so well, you want more exams, right? Because you have a higher chance of getting better scores the more exams you have. And so, so I do find that is the case. As you know, when I look at my blood sugars, the Dexcom tends to be higher. I mean, across the board, tends to be higher compared to the Libre. Okay, and we'll see something here in just a minute. All right, so let's go ahead and let's talk. Let's have a conversation about where we are and what we're doing. I'm so excited. So we've been talking for quite a bit about what we're doing in this space. So fasting and limitless living health action plan. And so let's go ahead and let's hop over and have our conversation. All right, so we've been talking about the Limitless Living Health Action Plan, and one of the interesting conversations that I love having is talking to people about what's going on metabolically and of course physically. So we've just seen some numbers, right? We've been tracking, and I love tracking. I love numbers. For instance, I love to track what the average blood sugar is. I love to track with the weight, and you guys will recall looking through, for example, my Fit Index, which is the app that I use to track my weight. Not only am I looking at my weight, right? Not only am I looking at that number right in the middle, but I'm also looking at these guys down here, right? So I'm looking at the weight, the BMI, body mass index, free body weight, and all those types of numbers, because I love seeing what happens as I do different things for myself. One of the beauties of the path that we're on, it is a path of education, empowerment, and encouragement. Remember the Triple E formula for success. And then empowerment comes from having tools that help you to implement the things that we learn under education. And so tonight we're doing something a little different. So I'm at 33 hours on my fast. And instead of just telling you how I feel or what's happening in my body, right, I'm actually going to go inside my most recent labs, and we're going to spend some time talking about what that looks like and what that means. That's right. I'm opening up my numbers, right? Not to brag, not to scare anybody, not to tell you about how bad things can be, but to show you exactly how to read the labs, what they mean, and why they matter for what we're doing in this space. Okay? So first question is, why do labs matter? We've been talking about playing your own game. And the truth is that most people only look at one number when it comes to health. Maybe it's the A1C, maybe it's the cholesterol, maybe it's their blood sugar that morning, but your health is not one number. Your health is a story. And every single lab test that we get tells a story or tells a part of the story. And so what I want to do is I want to help you to understand clearly that your labs are not a verdict. They are not a life sentence. They are actually feedback, just like those monitors that we're looking at. They're feedback. They're your body's way of saying, here's what's happening on the inside. Here's what's working, and here's what we still need to work on. That's the idea. And that's why fasting is so powerful, because fasting doesn't just move the scale, it moves all kinds of other things. It moves hormones, it moves inflammation, it shifts how your liver works, it shifts how your pancreas works, even how your brain is wired to process stress. And when you look at the labs through that lens, you start to see that healing. You start to see the healing is happening on paper, not just in the mirror. Now, the mirror is important too. As we've been doing our strength, strategy, and mindset series, one of the points I've been making there is that, yes, we are exercising, and yes, we're doing strength training. Not only should we see changes in labs, but I should be able to physically look in the mirror and see some benefits going on there, right? So tonight, we're going to walk through some different categories as we look at blood sugars, metabolism, because that's the foundation. That's what we're interested in. Then we'll move into cholesterol, lipids, because fasting is one of the most underrated, did I say underrated? Underrated tools for cholesterol control. And we'll make a couple of points there in a minute. So we'll check on what's going on with my kidneys. We'll check on some of the liver numbers. And of course, ultimately, a lot of people want to know, what is the A1C? What is the A1C? What is it? And so we'll talk about what the A1C is. And I'm going to use my own results. And this was just that we had, was it 2-3 weeks ago? I saw my doctor. So a couple weeks before that, I had labs. And we're going to walk through that and see what they look like. And then I want you to be able to say, that's how I can look at my own labs. I can look at my own numbers. That's how I can measure my progress beyond the scale, beyond what I'm seeing on the finger stick. And so I encourage people to track. You guys know that. I love tracking stuff. So I encourage people, when you go to your doctor, don't just take that piece of paper and, look at that one number that you guys talked about and fold it up and put it somewhere. There's a story that's being told on the labs that you have, and if you're not paying attention, then you're missing part of the story, right? So if you've ever been afraid of your labs, if you've ever thought, I don't even want to know what they are, or I have them, but I don't know what it means, then this is where you want to be. Because by the end of tonight, I want you to at least have a concept of some of the things that we're looking at, how to read them, and how those are correlated to the things that we're doing here. Okay? All right. So let's go ahead and let's hop over and let's talk about some of these. And the first part of what we look at is metabolism, right? And so there's a panel that's called the metabolic panel. It's called the metabolic panel. And it's called the metabolic panel because there are lots of markers on this that tells us about metabolism. Now, the one that what I'm going to show you is actually called a comprehensive metabolic panel because it has 14 different markers that we can look at. And so there's a simple called basic, BMP. So you may see that on your labs, called a basic metabolic panel. The one we're going to look at is called a comprehensive metabolic panel. The basic has some of the basic things that are there, but the comprehensive has about 14. It's called CMP 14. Okay, so let's go ahead and let's take a look at that. And so here you'll see, and this is my CMP, and this was, like I said, these were labs that were done just recently. I had them drawn on the 30th, and you'll see they're broken down. And what I've done on this chart is you'll see the last 4 sets of labs. So they're exactly the same labs, but the last 4 times that I got those done is what you're seeing right here. So back to October of last year, and then February, and then April, and then July. So that's just walking you through the last several months. And so what we're looking at is we're looking at numbers in the column that's closest to your left, that's on your left, right? So those are the most recent ones that we're looking at right now, and we're talking about these guys. Well, let's see. Let's see. How do we do that? We're talking about these guys right in here, and I don't know if I can write on that. I thought I would be able to. Okay, there we go. Okay, so we're looking at those guys right in that space. Okay, these are the ones that are most recent, and they're under that column that says July 30th. And so if you kind of scroll through or going down that column, you'll see several things there, starting with the sodium, and then the potassium, and then the creatinine, and then the calcium, and then the glucose. So looking at those first 4, sodium, potassium, calcium, glucose. So when I get labs, someone comes to the office, and I grab their labs and I walk into the room, I have a highlighter, or I have a pen, and, hey, how you doing today? What's been going on in your world these days? Anything going on that you want to specifically talk about before I get into my list? And we'll have conversations about what's going on with them, and they'll ask different questions. And then I grab the labs and I walk through them. Okay, so I'm looking at your sodium. The sodium is one of those big things that we look at when we talk about blood pressure, right? When we talk about nutrition, right? Depending on how you're eating, what you're eating, your sodium can be high or low. If you are dehydrated, the sodium can be high. So sometimes people will come in and their sodium is, 146, 150. And I look at some of the other numbers. For example, down at the bottom of that first column, you see something that says BUN, blood urea nitrogen. and albumin. So if your sodium is high and your BUN and albumin are high, that tells me that you're probably dehydrated, because what's happening there is that your blood is concentrated, right? There's not a lot of fluid, and so what happens is when we measure it, it looks like it's higher. So dehydration can be one way or one thing that happens that causes the elevation in the sodium, right? Potassium is another one. So people who are not eating a balanced diet can be deficient in potassium. People who have kidney problems, right, can have potassium issues. And we're very careful when it comes to potassium, because it's one of the most volatile. Not volatile. It's one of the numbers that needs to be in very tight control. And you'll see there, if you look right below that number there, that's 3.7, you'll see the range. 3.5 to 5.2 is what the range is, right? 3.5 to 5.2. And that is a very tight range. So dehydration can cause the potassium to go up. If somebody decides, hey, I like a lot of bananas, or I like a lot of greens, and they start eating a lot of those things, then the potassium can go up. Usually, if the kidneys are functioning well, then the kidneys will process that and it's not a big issue. But if you have some compromised kidneys for whatever reason, then you can see changes in the potassium. And then the next one down, the creatinine. Right now, my creatinine is 0.83. So the creatinine is a marker, and there are three markers that we look at for the kidneys. The creatinine is one, and we'll see two others here in just a little while. The creatinine is one, and you'll see the creatinine level is 0.75 to about 1.2, 1.27, almost 1.3. Your creatinine is a breakdown product from muscles. That's what that is. And so your body filters all of that out, and it excretes it through your urine and some other places as well. Well, if my kidneys aren't functioning well, when that breakdown product happens, then the body doesn't have the ability to excrete it, and so it stays in the body and it goes up. So an elevated creatinine is a signal that there may be some compromised kidney function. Now, one of the ways that can happen when there's not compromised kidney function is like if you all of a sudden, I shouldn't say all of a sudden, like if you're out and you're training really hard and you're dehydrated, remember the kidneys are supposed to be filtering. Well, if I'm out training, right, so whether I'm running or I'm lifting, it's hot out, I'm not drinking enough water, what begins to happen is that the creatinine is breaking down from the muscles, because it's a muscle breakdown product, is breaking down from the muscles, but I don't have enough fluid on board to flush it out. And so the creatinine goes up, not because there's a kidney problem, but because I'm putting in too much creatinine in and not giving the body the ability to flush it out. So that's one way that the creatinine can be elevated when there's not a kidney problem per se. Okay, so that's the creatinine. And then the next one down is the calcium. So these are the fundamental, some of the basic electrolytes that you will see in your body. And so calcium can be high or low. Once again, it can be high if you're dehydrated. It can be high if you fell and you broke a bone. It can be high if you have osteoporosis, because the body is doing some different things. It could be high if you, for instance, if you have indigestion, right? And you take a lot of Tums, well, guess what happens? Yeah, the calcium goes up. And it's not because there's a problem, it's because you're eating a lot of calcium. So whenever I see someone with elevated calcium, I go through a list, right? We talk about, okay, hey, what's coming in from outside? Okay, go through the diet. What are you eating? Are you drinking a lot of milk? Are you taking Tums for indigestion? Are you eating a lot of greens? There are certain medications that can also do that. Like if you're on a hydrochlorothiazide, one of those thiazide diuretics, they can cause elevated calciums. When there's not a body problem, in other words, it's not an issue in your body, we're doing it to you because the medication is causing it. On the other end, we can have a low calcium. So people can have low calcium if they're not eating well, they don't have a balanced diet. So once again, I guess that's a good point to make here. is that the electrolytes that we see can all be dysfunctional, or they can all be off based on our diet. So if there's a thing called tea and toast, right? So people who have low sodium, and we call them tea and toast, because if you're not eating a balanced diet and just drinking tea and eating toast, then that's not a balanced diet, and those people will have low sodium because they're not taking in enough. Okay, so once again, so sodium, potassium, calcium levels can all fluctuate based on what's going on in your diet. And then if you look all the way down at the bottom, the one that says albumin, the albumin is a marker that we will use in the hospital to tell whether somebody is having good nutrition. So if the albumin is low, then we'll say, hey, I wonder if this person is not eating well. And so we can look, we look at your body weight, we look at the other electrolytes, we look at the albumin, and we can have an assessment. That's why this is called the metabolic panel, because it tells me, what is metabolism, by the way? Metabolism is how your body is converting food to energy. So this panel tells me about what's going on in your food and how your body is using it. Okay, so from the metabolic panel, that's one of the things I want you to get, that all of these things are a marker of what's going on food-wise. Not just that, but that's the main idea. There's some other things we can look at as well. So sodium, potassium, creatinine, the calcium, right? Of course, glucose, and we're going to skip that for now because we're going to come back and talk about glucose, because that's ultimately the whole diabetes thing. Look, notice what my glucose was. When I got my blood work at the time, my glucose was 66. Right? Glucose was 66. And once again, a marker of what's going on in terms of my metabolism. So good. That's a good marker of what's happening. And so at the time I was 66, and I'm going to tell you about a conversation I had with my doctor here when we get to one of these other. We'll get to one of these other things. Okay, so that's the first part of the CMP, or complete metabolic panel. Like I said, there are 14 things that are there that we can look at. Let's go ahead and look at this second set that's in that 14. And once again, looking at that column that's to the left, and it starts out with carbon dioxide, total carbon dioxide. Remember, carbon dioxide is the opposite of oxygen. So when I breathe in, I'm breathing in oxygen, and in my body, the body's doing all the things it needs to do to live, and it produces carbon dioxide, and then I breathe that out. So what are some things that can cause elevated carbon dioxide? What do you think? Well, if I'm not processing energy or processing oxygen correctly. In other words, if I'm hypoxic, in other words, I'm not getting enough oxygen. If I'm not getting enough oxygen in, then my body is by nature holding on to some of the air that I breathe in and trying to extract more oxygen from it. And if the air stays in there long enough, then carbon dioxide goes up. Or if my body is not getting oxygen, then the cells are processing without oxygen, and so they generate more carbon dioxide. Make sense? So things like, and it's called hypercapnia. That is, so hypoxia or hypoxia is low oxygen, for example. Hyper would be high. Capnia meaning carbon dioxide, hypercapnia. So people who have sleep apnea, they can have a elevated baseline carbon dioxide. In other words, so what's happening is when they're sleeping, their body is not getting enough oxygen, and so they build up carbon dioxide in their body. And so they tend to live at a higher carbon dioxide ratio compared to people who don't have sleep apnea. So that's the carbon dioxide. The bilirubin, the alk-phos, the AST that you see there, and the ALT, those are all markers either of your gallbladder or of your liver. The bilirubin is a gallbladder thing. You can get it from other places, right? So, for instance, your liver produces some stuff. But for the most part, if you have an elevated bilirubin, a lot of times we'll look at the gallbladder. If you don't have a gallbladder, we say, hey, it's not coming from the gallbladder, it's coming from somewhere else. And then AST and ALT, the SGOT or SGPT, and you'll see those both in different ways on your labs when you get them. Those are markers of how the liver is doing. So when they go up, then we worry that people have fatty livers. They have maybe some kind of hepatic dysfunction. Maybe they have hepatitis. Maybe there's medication, for instance, acetaminophen, which is Tylenol, can affect the liver. So you should not. Well, that's a you should not. But when we take too much of that, that can cause liver damage, and the liver damage shows up as an elevated AST and an elevated ALT. And then all the way down at the bottom, there's that one that's called the GFR or eGFR. This is the second marker of the kidney function. So let's go through that again. Remember, we looked at creatinine, and the creatinine, as I say, is a breakdown product from the muscles. And so if your kidneys aren't filtering properly, then the creatinine will go up because the body is not able to get rid of it. Make sense? All right. Well, I want you to think of the kidneys, and the kidneys are designed to have, it's basically a filtration system. It's kind of like in my refrigerator. I get, the water filter, and I get a new one, and I plug it in, and we process the water, and it tells me on the thing how much water can be processed through this filter before I have to get a new filter. So there's a certain volume of water that I can process through that before I have to get another one. Well, there's a certain volume of blood that the kidney is supposed to be filtering. Right, that's that number. And as the kidneys get less and less able to do that, the total volume and the rate at which it's filtering goes down. And that's that term that we saw there called the glomerular filtration rate. That is the rate at which the kidneys are able to take your blood and to clean it out. And when that number goes down, that means that my kidneys are less and less able to do what it's supposed to do. It's kind of like going back to the little filtration thing. So on the refrigerator, there's an indicator, and it'll say, so if I put it in, and we've been using it, and then on the refrigerator, there's a little indicator that comes up that says you need to order a new filter. Now, it doesn't say I have to change it. It says, hey, it's about time to go ahead and order one because soon you're going to have to replace it. So you can imagine at that time that the ability of the filter to filter the stuff that's coming through the water is starting to get to the point where, hey, we're going to need to do one. And if I don't do that, I want you to process this. If I don't change it, right, after it says, hey, guy, I've been telling you now for the last 2 weeks, did you get one? And I say, no, I didn't get one. Then it stops being able to filter the water. The water is still coming through, but it's not being cleaned. And so the GFR, the glomerular filtration rate, is the rate at which the body's still able, or kidneys specifically, is still able to do what it needs to do to clean my blood. And if it can't do that, then we can run into trouble, run into problems. So normal is anywhere above 60 for African Americans and 59 for Caucasians. And so if the GFR drops, if I see a high creatinine, that other number, and a low GFR, that tells me that something's going on with the kidney, so it's not able to filter the stuff out, and the rate at which it can do it is going down. So I usually send people to see the kidney doctor at that point. And there are 3 numbers, and we'll come to the third one in a minute because it's on a different panel. So if I get any 2 of those, I'll send someone to see a kidney doctor. Or if I have one that's grossly abnormal, for example, your creatinine is supposed to be, like I said, 0.7 to 1.2. That's normal. So if I see a creatinine of 1.21, and everything else is normal, we check it again. But if all of a sudden I see a creatinine that goes from 1.1 to 1.9, that's a visit to the kidney doctor, regardless of what the other two are showing. Or if I see a GFR that goes from normal, which is, above 60, and all of a sudden it goes down to 3, regardless of what the other two are saying, guess what? You get to see a kidney doctor. So that's what's going on there. And so that is the complete metabolic panel. Complete metabolic panel. The next one is the complete blood count. CBC is what it's called. And on the CBC, there are two main things I look at, and we'll talk about that in a minute, for metabolism and for diabetes. There are lots of other things that we can look at for other diseases. When we're talking about metabolism, there are a few things that we look at. We'll walk through those 2 or 3 so that you understand what they are. But there are other numbers. For example, when I talk to patients who have thyroid disease, I put them on a medication that's called methimazole, or something called PTU, propylthiouracil, one of those medications. And those medications can affect the white count. And so when I'm looking at the white count for those people, I'm actually looking at something a little different than I'm looking at when I'm looking for somebody who has metabolic disease. Okay? So once again, we're looking at that first column on the left, and that tells you all the different components on this complete blood count. And that's what the CBC stands for, complete blood count. And when you look at the complete blood count, there are 3 or 4 different types of cells that we look at. Number one are the white cells. And the white cells are the group of cells that are responsible for inflammation and for your protection from infection. Right? So when viruses come in, when bacteria come in fact, not just that, but if you have parasites or even if you get a cut, then those cells are the ones that are responsible for taking care of all of that. And that's what the white count is. So if I have a low white count, then that can mean that my ability to fight infection or to mount an inflammatory response, for instance, if you get a bruise or a cut, the process that fixes that or deals with it is an inflammatory response. So sometimes we talk about inflammation like inflammation is bad. Inflammation actually is good, because inflammation is the body's mechanism for keeping things at bay or keeping things in check. It's when inflammation goes awry. Oh, this is a great point to be made here. The body loves homeostasis. And homeostasis is the process of staying, this idea of sameness. Like all these numbers that I'm telling you about, they're supposed to be in a certain range. For example, we talked about the creatinine, 0.7 to 1.2. That's the range. And so the body's always in the process of trying to stay there. For potassium, 3.2 to 5.2, or 3.5 to 5.2. The body is trying to keep it there. And anytime it goes outside of the range, the body tries to bring it back. So if all of a sudden your sodium goes up for whatever reason, your body will hold on to water to try to dilute the sodium. And that's where blood pressure can come from. Oh, this is a good one. Right? So if all of a sudden you go out and you're, so over the weekend and you're downing food that has all kinds of potassium or salt in it, right? Eating popcorns and potato chips and, soups that have a lot of sodium in it. And so your sodium level is actually going up in your body. The body sees that and it says, hey, I don't like the fact that my sodium is going up. So how do I dilute the sodium? Well, I get the kidneys to retain more fluid. And when I retain more fluid, right, there's more pressure. When there's more pressure, blood pressure goes up. So that's the correlation between salt and water and blood pressure. Okay? So homeostasis, the body's always trying to stay in the sameness. And when it can't do that, that causes dysfunction. So back to inflammation, the body is trying to correct whatever it is. I see a bacteria, so I'm going to fight it. I see a virus, so I'm going to fight it. They got a cut, so I'm going to send some cells over there to deal with the cut. That's called inflammation. And if the body doesn't do that, then the infection gets bad and it puts the entire body at risk. So we can die as a result. And so the body says, we don't want that. So I'm sending an inflammatory response over there. When it gets there and it deals with it and it goes away, everything is fine. But it's when the inflammation becomes over stimulated that causes the issue. So inflammation itself is not bad. It is overstimulation of inflammation, and that goes along with a lot of things that we've talked about before. Okay, it's the overage that causes the problem. All right, so that's the white count. So white count is high, causes the white count is low, causes a problem, which means that the body can't mount a fight against whatever it is. So that's low. How about on the other side? What does it mean if I've got too many cells? Well, number one, it can mean dehydration, right? So anytime there's dehydration, all of these numbers can go up. Dehydration is number one. Number two, it can mean that I'm stressed. So the body sees stress as a danger. And anytime there's a danger in the body begins to mobilize the fighting mechanism within itself. And this is called stress demargination. So someone will come into the hospital and we check their white count and it's like really, really high. And we check it tomorrow and it's lower. We'll say, hey, what happened last night? Why was that high? Well, the person's not dehydrated. It's that their body was under stress and all of the cells, stress demargination, all the cells that were out there ready to fight, they all came out. And so you can have a high white count. Now, the other thing that can signify, remember, abnormal growth is what we call cancer. So having an elevated white count, if it's persistently elevated, can be that there's something else going on in the bone marrow, in the tissue, leukemia, those types of things. And so those are things that you want to make sure that you are talking to a healthcare provider about. And this is a great point to say that this is informative. This is not diagnostic. What we're talking about right here, this is not a diagnostic session. This is an information session. So if you have specific things that are going on in your numbers, you need to make sure that you have someone that's looking at those and giving you advice. All right, so that's the white count. The next group that I look at is down there where it says H&H, hemoglobin and hematocrit. So the white count, those are the cells that fight infection and produce inflammation and so forth. The red cells are the cells that are responsible for bringing oxygen in and bringing nutrients to the cells and taking carbon dioxide and waste away. So they're the transport system that brings oxygen in and takes waste away. So let's talk about what happens if it's high, what happens if it's low. Let's talk about low first. If you are anemic, that's what that term means. So if you have low red cells, it's called anemia. A meaning not, emia means blood, not enough blood. So anemia. So if my blood cells are low, so I don't have enough, then my ability to carry oxygen and nutrient to the cells, my ability to do that goes down. So I want you to walk through this process. So if the cells that are responsible for bringing energy to the cells, to the other cells, can't do that effectively, what do you think people will feel like? What do you think they would complain of? Well, they'll complain of fatigue because I'm not feeding the cells. They'll complain of shortness of breath. They'll complain of dry skin, dry hair, dry nails. Why? Because the body is not able to adequately give energy and give nutrients to the cells that require it. So when someone is anemic, and there are lots of things that can cause anemia, when someone's anemic, then that causes problems downstream for us. So when I'm seeing patients, I'm looking to see, are they anemic? People who are diabetic can be anemic. So it's called anemia of chronic disease. Anytime there's a chronic disease, that disease can cause problems for anemia, right? So people can have those issues. And so I look at that to make sure that there's not anything going on there. And so I say, hey, we need to, are you taking iron? Are you B12 deficient? Are you losing blood somewhere? For instance, in your stool, do you have dark stools, bright red stools? Are you seeing any blood when you use the restroom? All those things can cause issues for anemia. So one of the things that I look at there. Okay, and we're gonna skip over some of these others, but well, let's look at the one that's right below hematocrit. So we got hemoglobin, hematocrit, and there's one called MCV, or mean corpuscular volume. That tells me how big the cells are. Okay, so if the cells are really tiny, then they can't really do what I need them to do, right, in terms of carrying capacity. If the cells are really big, they can cause problems. Remember, once again, we're trying to stay homeostatic. We're trying to stay in the range. We're not trying to be too big. We're not trying to be too small. And so that MCV will tell me what's going on with those numbers. All right. And then this next set is one that everybody kind of hears of, and this is the fasting lipid panel. And you can get a panel that is not fasting, by the way, because you're looking at different things. So fasting lipid panel just tells me what's going on with my cholesterol. And there are several cholesterol numbers that we can talk about. There's the total cholesterol. There are triglycerides. There's the HDL and then the LDL. So let's walk through those together. The total one, we're going to kind of skip that for now because the total really is just a sum of all the others. Right, it's essentially. There's some other nuances which we won't get into. So total we're going to skip for now. The bad cholesterol is the one that everybody talks about, and it is the cholesterol that's responsible for basically clogging the arteries. So let's process this together. So when you eat food, if the body has to store it, it sends it to the fat cells, and it's stored in the fat cells. When we have to take it out of the fat cells for whatever reason, then it's in the form of what's called triglycerides. So the LDL is when I package it up and I'm sending it through the blood to go to storage. So the more fat I eat, the more sugar I eat, the more my body has to package to send to storage, the higher my LDL can be. And because it's high, when it's traveling through the blood, it has the potential for either clogging the arteries, or it causes an inflammatory process to happen in the blood vessels, and then that sets off a whole nother cascade. So that's the LDL, that's the bad cholesterol. Well, if we talk about bad cholesterol, let's talk about good cholesterol. What's the function of the good cholesterol? Well, the good cholesterol, I liken it to like Roto-Rooter. Right, so if you guys remember Roto-Rooter, right? So basically, Roto-Rooter was, these guys they did plumbing, the toilet, and they would come and they would rooter it out, right? They had the little thing that they put down and they turn it around, and so if the bad cholesterol is clogging the arteries, then the good cholesterol actually comes along and then does this, right? It's basically taking all that stuff up. That's why we need a lot of good cholesterol and less bad cholesterol. Because if we have less bad cholesterol, it doesn't clog the arteries. And if we have a lot of good cholesterol, if the arteries get clogged, then it can go in there and it can rotor it out. That makes sense so far? Okay. And then, of course, triglycerides. Triglycerides are when my body is storing the stuff that's inside. It's called triglycerides. So triglycerides. Now, the more sugar we eat, and this is a point that I want to make, because everybody talks about eating high-fat foods causing high cholesterol, and that is true. But one of the things that has a bigger impact on cholesterol than fatty food is sugar. Because what has to happen if your blood sugar is high? The body has to take that sugar and do something with it. And if it's storing it, it converts it, it packages it, and those things become triglycerides. So when I see somebody at the hospital, they come in with high triglycerides and say, hey, what are we going to do? What are we going to treat? Because we had somebody who had triglycerides like a couple of thousands, right? 4,000, 5,000, 6,000, whatever it is. What are we going to do? What are we going to do? I said, stop feeding them. I said, what do you mean? I said, well, if we don't put anything in, guess what the body has to do? It has to use it up. So they come in and we say, hey, you're going to fast for X number of days. And if you're in the community now, you know that we can fast. And so we fast them for X number of days and the triglycerides begin coming down. And then we say to them, hey, when you go home, don't eat as many carbs. Okay? All right. So that's the bad cholesterol, the good cholesterol, and of course the triglycerides. And the total is just a sum of the two. There's some ratios that we talk about. And for instance, you see mine there. My LDL is 84. We like that to be less than 100. In some cases, people will say less than 70. The triglycerides, we want it to be less than 150, because 150 is the upper limit. Mine is 45. My good cholesterol, we like that to be over 50, and mine is 87. Right? So a lot of that, for instance, the triglycerides, the reason the triglycerides are that low is because I am fasting and my body is using that up. So it's not sending a lot of stuff for storage. Same thing for the LDL. Okay? That's the fasting lipid panel. And then this is the third number, the microalbumin. So we said creatinine is a marker of kidney function. The GFR is a marker of kidney function. And then the microalbumin is a marker of what's going on in the kidneys. So for this one, I want you to think of the kidneys kind of like a sieve, a strainer. And it has those holes, right? So you're basically like a cheesecloth. And you're straining things through it. Well, if those holes are big, then things that shouldn't go through will pass through. That's why sometimes they, depending on what you're cooking, they say use a cheesecloth because it has the really, really fine and it strains out a lot of the gunk. Well, diabetes causes the holes to get bigger. And so things that should not pass through, all of a sudden is going through. And so if we see elevated microalbumin, that can be a marker of the fact that there's something going on in the kidney. So creatinine is a kidney function. The GFR is the rate at which we're filtering, and the microalbumin is, is there damage to the kidneys? So those three numbers, when I look at those, I'm looking specifically for kidney function. And anytime I see grossly abnormal numbers in any of those, then you get to see the kidney doctor. If it's slightly abnormal, we'll check it again, and then we go from there. Okay? All right, so that is kidney function. We've talked about fasting lipid. And then, y'all, you guys ready? You thought we were going to do A1C. But here's the TSH, thyroid. And so the thyroid, three numbers we look at, TSH comes from the brain. Free T3 and free T4 come from the thyroid itself. And so I think about the thyroid kind of like a seesaw, with the TSH coming from the brain and the free T3, free T4 coming from the thyroid itself. And so we want the seesaw to be balanced. And if I have an elevated TSH, that means my thyroid is not producing enough. If I have a low TSH, that means my thyroid is producing too much. Because they always go in opposite directions. A lot of times I'll get patients who are sent to me not because they're in one direction or the other, but because the seesaw is broken. Like it's supposed to be like this, up or down, but sometimes both of them are down, or sometimes both of them are up. And so the doctors will send them to me and say, hey, well, this doesn't follow the rules. So what's going on? And so we do an evaluation to see what's going on in that case. And those are the thyroid functions. Okay? Awesome. And then let's go ahead and let's talk about, now we're getting into some important ones. Well, everything is important, but some different ones now. And so C-peptide. So C-peptide is a function, is a marker of kidney, of insulin. So I want you to think about the C-peptide as like if you have a banana, right? There's the banana on the inside, and there's the peel that goes over the banana. And so if you walked into a room and you saw 5 banana peels, you would say, hey, somebody ate 5 bananas. Make sense? Well, when the body makes insulin, it doesn't make it as insulin. It makes it kind of like a package. There's the thing that we call insulin, and then it's packaged inside the C-peptide or packaged with the C-peptide. So if someone is on insulin, and I go to measure their insulin, I don't know, am I measuring insulin from their body or am I measuring insulin that came from outside? And so what I do that is I look at the C-peptide, because the only place you get C-peptide from is from the inside. So if their C-peptide is high or normal, then I know their body is still making insulin. And insulin changes, right? So depending on what happens to your blood sugar, it can be high or low, but the C-peptide is usually pretty consistent. And we'll see an example here in a minute where it is a little confusing. In fact, let's look at that right now. So if I have someone who's not making any C-peptide, meaning their insulin is not being produced in their body, I call them a type 1 diabetic. I'm going to let you pause for a minute. So my diagnosis is type 2 diabetes. But if you look at my C-peptide, right, the most recent one, it's 0.8, which is low, which means that my body is not at the time making insulin. So anybody looking at that number, if they're not taking it in context, would say, hey, Dr. Woode, you're a type 1 diabetic. Well, if you remember when we went, and let's scroll back through here. Let's go back to this one, which was the CMP, right? Complete Metabolic Panel, was my blood sugar was 66. So if my blood sugar is low, there's no reason at that time that my body would make insulin. And this is one of the things that we need to be able to do, right? To talk to people about the correlation between what's going on at this moment, right? So when I'm fasting, my blood sugar is low, and I've told you when the blood sugar is low, insulin is low. Well, here's the example. So my blood sugar is low. It was 66 when I got my blood work done. And when they measured the marker of my insulin, it was also low, telling me that because the blood sugar is low, then my body was not producing insulin at the time. So if we go back over there and we look further back, we'll see that prior to that, my C-peptide was 1.8. Before that, it was 1.4. Before that, it was 2.5. So my body is producing insulin. At those other times, my blood sugar was higher compared to what it was at the time. Because this time I got it while I was fasting. The other times I probably didn't do it when I was fasting. I just went in to get blood work. And then below that is testosterone. And testosterone level will fluctuate depending on what's going on for guys. And, well, both women and men have testosterone, by the way. Right? Women's testosterone tends to be lower. And so for my guys, one of the places where testosterone suffers, or things that causes low testosterone, is obesity. Because remember, testosterone is generated and it's regulated when you're sleeping. So if you have obesity and you have sleep apnea, then you're not sleeping well, and because of that, testosterone goes down. Right? So it's a cycle there. And you see my total testosterone is 485. The free testosterone was low in this case, and it is volatile. It changes. And we treat based on the total testosterone. So if somebody has low testosterone, we're looking at the total. It says, hey, you need to be on some testosterone treatment. And then let's take a look at my PSA. So prostate-specific antigen. So my gentlemen, my guys who are out there, this is one of those things that your doctor should be checking. All right, your PSA, prostate-specific antigen. And it tells us whether the prostate, well, there's several things that can cause it. So an enlarged prostate can cause it. If it's changing quickly, that can be prostate cancer, right? But it doesn't always mean that. So one of the reasons that a lot of guys don't get this checked is because they're afraid that they have cancer. Well, knowing is better than not knowing, because if we know, then we can do something about it. If we don't know, then it stays there and it gets worse and worse and worse. Okay? And then, are you guys ready? So what do you think my A1C would be? Right? My A1C would be. And so we've been looking at A1Cs, we've been tracking them, and so my average A1C over the course of time based on my monitors has been anywhere from 5.6 to 6.1. In fact, when we look at my numbers right now for 90 days, right? So based on this, right, my average blood sugar is 118, and my estimated, or my GMI, glucose management indicator, A1C, would be a 6.1. Going back several weeks ago, my estimated A1C was a 5.8, was what we got. And so if I go back to this and I look at what my number actually was, then my A1C at the time was a 5.6, which is right in keeping with where I expected it to be. As I said, the GMI is a surrogate for the A1C, right? We can't call it an A1C because it's a calculated number, but it should approximate where your A1C is. And so here we are, right? And here we are with an A1C 5.6, which is in the non-diabetic, right? Because you have to be a 6.5 to be diabetic, and it's not in the non-pre-diabetic, because you have to be 5.7 to 6.4 to be diabetic or pre-diabetic. So it is actually in the normal range, so below 5.7. And what have we been doing over the course of the last several months? We've been walking through the health action plan. So A1C is lower, my insulin level is lower, my weight is down, my cholesterol level is down. There's no marker of kidney damage as indicated by the creatinine or the GFR or the microalbumin. My testosterone level is in the normal range. So all of those are indicators. Those are indicators of what's going on metabolically. And so when I went to my doctor, one of the conversations we had is he was like, "Hey, so tell me what you're doing." And we always have this. I said, "Oh, I'm fasting," and go through the health action plan with him. And he said, "Really?" And when he first saw it, he said, "Are you a type 1 or type? I thought you were type 2. I thought you were type 2." I said, "I am." He's like, "Well, your C-peptide is low." Right? So remember, looking at that one number gives you one idea. But now I have to say, no, well, remember that I'm fasting. So my glucose was 66. So at a 66, my body doesn't have to make any insulin. And so that's why the C-peptide is low. So looking at all those numbers, and let's go back and let's take a look at what was going on before. So if you see the 4 prior to that, right, you'll see 6.4, and then 7.5, then 6.4, and then 5.6 is what the most recent one is. Right? So that's the journey. That's the process that we go through. And so the goal is when we treat diabetics, we tell them we want their A1C to be 6.5 or lower. 6.5 or lower. And you recall the one there that's 7.5, that was when I had COVID back in the December area, and my blood sugars were probably about 60 to 70 points higher as a result. And so as they came down, now we see that A1C getting better and better, blood sugars are better. And so one of the questions people ask me is, how do I get my A1C down? And I say to them, get your A1C down by getting your blood sugar down. They said, well, they said that this medication will fix my A1C. Let me say this to you now. There is no way to fix an A1C without fixing blood sugar. So you can't have blood sugars that are 200s with an A1C that's normal. So anytime you hear somebody say, I'm going to fix the A1C, the question you want to ask is, how am I going to fix the blood sugar? Because if I fix the blood sugar, then I get a better A1C. And that's the process. So when we talk about labs, remember the labs are designed to be a window. They're telling a story. So the bottom line is that they all give you a glimpse into what's going on in your body metabolically. And so you want to understand not just that number, that one number that everybody talks about. Remember, we're playing our own game. And playing our own game means that we are looking at more than just that one number, because we're trying to stay alive as long as possible and stay as healthy as possible. And if we're going to do that, we have to understand what's going on in our body. So the labs are tools. They're not a judgment against you. They track your own journey. They help you apply the changes that you want to get the benefit that you're looking for. So they're just mileposts, or they're indicators. There's not a judgment. And if you haven't checked your labs, if you've not had labs checked, this is your nudge. Knowledge is power, but only when you use it. And so as we've walked along this journey, the health action plan, limitless living, right? The balanced bites, as we've talked about fasting, as we talked about strength, strategy, and mindset, our weight training, we've talked about walking. All of those are tools. And the tools allow us to put into place, into practice, things that will help us move in the direction of long, healthy life. And we are tracking that by looking at labs. So labs they're a glimpse into what's going on. And we want to make sure that we're doing everything we can and using every possible tool, every possible indicator to move us in that direction. So don't be afraid of labs. But we want to make sure that we understand what those numbers are. Learn from them. Learn what they mean. That's how we live a limitless life. By looking at these. Stay tuned. All right, so I see we have some questions out there, so let me go ahead and take a look at that. So that's the lab. So I wanted to make sure that everybody understood what's going on with labs. So I see Jennifer said, let's see, where were we? So Steve was there. Jennifer says, she said, I'm back, ran out to get my lab report. Had them done 3 weeks ago. Jeff says, crazy that I got my lab results today. My A1C is holding steady at 5.6 with just low carb. There you go. There you go, Jeff. Congratulations. 5.6. We're lab partners. Jennifer said, hoo-hoo, congratulations. Yeah, Jeff. And Jeff says, what about low creatinine but higher AST, ALT? Recently, 10 milligrams of Systemivy was added for my 10 milligrams of rosuvastatin. Also, lipids seem too low with cholesterol is 76, LDL 31. So here's it, and so Jeff, as I say to everybody, make sure that you are talking with healthcare providers. So one of the things that we sometimes get turned around is this idea of cholesterol. So we're used to cholesterol as being in the hundreds, right? But if I take a baby when the baby is born and I check the cholesterol is not in the hundreds. It's in it's in low numbers. It is our diet and our lifestyle that brings our cholesterol up to the levels that they are. And so what we have done is we have normalized, when we get labs, the labs are based, the levels are based on what we in our society have seen in the population. But if we go to a different population that doesn't eat like us, their lab values actually are shifted lower. And so when we look at these numbers, we've talked about cholesterol, LDL, and so forth. The question, the argument that's going on in a lot of places is there such a thing as too low cholesterol? Now, one of the arguments for that being the case, that you can have too low cholesterol, is that several of the hormones come from cholesterol. And so the idea is, if my cholesterol is too low, then those hormones, we don't have enough cholesterol to create the hormones. It's an argument. It's an argument. When we look at cholesterol as it relates to heart disease in diabetics, one of the reasons we put diabetics on cholesterol medication is because there seems to be some non-cholesterol lowering benefit that come from statins, right? There's rosuvastatin, simvastatin, anyway, the statins. So that if I have someone and I put them on two medications, right, a statin and a non-statin, like azithromycin, and both of those lower the cholesterol the same amount, the person seems to get additional benefit from being on the statin in terms of their heart compared to the other medication that lowered the A1C or lowered the cholesterol. So that people who lower A1 or cholesterol on two different medications, one a statin and one not a statin, the people who don't do the statin seem to still have heart disease, more heart disease compared to the person that's on the statin. And that's why they say all diabetics should be on a statin, because they seem to have some non-cholesterol lowering benefits to the statin. Sometimes I'll see somebody who's on one of the statins, and they're on 5 milligrams. Well, you actually have to be on 10 milligrams for the statin to have the heart benefit. So simply being on statin is not important. That's not just the answer. You have to have some benefit. Hey, Toad Hello says, what's good, man? Hey, thanks for coming through. And Jeff says, let's see, labs were done by Virtual LabCorp for free via our insurance. I did email my PCP with questions because creatinine was low, AST, ALT were higher, but not above 40, and lipids much lower, blah, 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 blah. Okay, so great. You didn't ask this question, but I'm going to answer this question here. So normal is normal. So I have people who have, for instance, thyroid disease, and they don't have thyroid disease, but they come in and, this year their TSH is higher than it was last year. It's like, last year was 1, this year is 1.2. But the normal for TSH is 0.5 to 4.5. So if it's in the range, it's still considered normal. So even though it may be going up. Now, let's have a conversation about what could be happening. So sometimes people have immune issues going on with their thyroid, and I'm using thyroid as just an example. You can use this for any other disease process. And it could be an indication that something's going on in the thyroid, but we don't treat those until there's an issue. So if I have someone whose A1C is climbing, right, we say to them, hey, your A1C last year was 5.6. This year is 5.7. You're pre-diabetic. Hey, this year is 5.8. Well, yeah, we need to like look at that and say, what do we do to head it back in the other direction? Because the elevated A1C is an indication that the blood sugar is higher. Because you can't get a higher A1C without having higher sugars. Generally speaking, I mean, there are some specific disease processes where that can happen. But yeah, you have to have higher blood sugars to get higher A1C. So if the A1C is going up, then we need to do something to head it back in the other direction. And that's that whole idea of metabolic dysfunction. And Jeff says, sorry to ask so many specific questions, just never seen such big changes in labs. Hopefully my PCP email me back tomorrow, blah, blah, blah. Yes, definitely. And so if you're out there and you have specific questions, then make sure you are talking to your primary care doctor. In our community, of course, we have conversations around labs. So join our community, and we can have those conversations. But specifically, if you have specific questions about your disease or labs, make sure you're touching base with your healthcare provider. Okay, awesome. All right. Well, so once again, back to our concept of labs. So labs are designed to be indicators and markers to help you on the journey. And that's why the Triple E formula for success is so important. We educate, we empower, and we encourage. We educate to help you understand how your body works, how food interacts with your body, how your body processes. Because if you can understand that, if you have the ability to see what's going on in your body, you get to make choices. And we make choices, we make good choices when we have enough information and we understand it. The reason we make choices that don't seem to be in keeping with good health is that we don't really understand. And even if we do understand, we've made it so complicated that when the brain sees complication, it really defaults to doing nothing. It's kind of like, that's why when you go to the store, right, when they have a sale, they don't tell you you can get this or 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 the other, right? They say you can get this or this. Why? Because they know if they give you too many choices, the brain's going to get confused and you're not going to buy anything. Or sometimes you go in and they just have that thing for sale. Because a confused mind doesn't buy. So a confused mind does not make decisions that are consistent with what we think should happen in terms of our metabolism. So we educate, change the perspective, change how you think, change the angle at which you're looking at this thing. How does my body work? What can I do to improve it? What things are affecting it? So we educate, we empower the tools that you're learning, right? For instance, we just did a tool. The tool is understanding what's going on with our labs. The health action plan, COPE model, the HEAT model, all of those are designed to help you implement effectively the things that you do that we learn under the education component. That's why the plan is called the health action plan, meaning that you've got to put some energy into it. You've got to do something. Simply listening is great. I love the fact that you guys listen. I love the fact that you're here. I love the fact that the videos are being used. But that doesn't matter if you are not infusing it with your behavior. I'm gonna pause there. The things we learn come alive with your behavior and your action. And then we encourage, we educate, we empower, and we encourage. We encourage with the community that you're part of, right? Come on, share your story, share your challenges, share where you are having benefit. And we have people who are having tremendous weight improvement. People are having tremendous A1C lowering, tremendous blood pressure lowering. People are getting off of medication. Share those stories, because when you share the stories, other people see that and say, hey, if they can do it, I can do that too. One of the reasons I share my numbers is so that you can see these are real numbers. You see where I was. In fact, we'll go back at one point and show you my A1C when it was above 14. Yeah. So how do we get from there to a 5.6? That's the question. And it's really not just about the 5.6. It's about how do I keep you alive as long as possible and keep you as healthy as possible. That's the ultimate goal. And all of these things, we just talked about the labs, we just talked about that, they are simply indicators. They're not the goal. The benefits that we're getting in terms of weight and blood pressure and blood sugar and A1C, they are side effects of us being healthy. And that comes through the Triple E formula. We educate, we empower, and we encourage. If you've not joined our community yet, go ahead and do that. There's a join button down there somewhere, right? Hit the button and become a part of the community so that we can all walk along together. If you're tired of being on that wheel and you're ready to install this process, this operating system into your life so that it becomes a default on the website, our accelerator program, go ahead and join that. And let's walk through this process together so that we can keep you alive as long as possible and as healthy as possible. Remember, the goal is for you to be able to romp and play with your grandkids, for you to see your son, your daughter graduate college and get married and start a family, for you to finally pass the business on to whoever you're passing it on to, and for you and your significant other, for your family to travel and do all the things that you wanted to do. That's our goal. Our goal is really not that A1C. The A1C is simply a marker of what's going on. But our goal is to keep you alive as long as possible and keep you as healthy as possible. Love it, love it, love it. And so we continue our quest and continue our journey. I shouldn't say quest, continue our journey for improving our health and for reversing our metabolism as we move through this metabolic space. We will be back tomorrow with our check-in at 48 hours, right around 1:30-ish tomorrow afternoon. We'll be back here in the space with our show tomorrow night. On Friday, we'll do our complete review of fasting, where we talk about how to get into a fast, preparing for it, how to get through the fast, and then, of course, how to break the fast. And you get to see what I'm going to eat for the first time after 72 hours of fasting. Come on back and hang out with us. Join our community. We're always excited when people come through. When you show up, tell your story, get involved. And the benefits that you're getting, go share that with somebody else. Limitless Living says that we don't do this alone, but we are improving our community around us, because when the community gets better, we all get better. I'm always excited when I get to hang out with you. Always excited when I get to see your benefit, and I'm always excited when I get to walk along this path with you. Hey, I'm Dr. Dwain Woode. That's Wood with an E. The E stands for endocrinology. Here I educate, I empower, and I encourage you to take charge of your health and your life. Avoid complications. Go to the next level. We're creating the life we've always wanted, and we are living limitless lives, which says that we're not allowing nothing from outside or nothing from inside to prevent us from doing what we need to do. We're showing up with our best selves, our best health, and our best plans. Good night, everybody. We'll see you in the community. We'll see you along these digital streets, and we'll see you as we extend a long, healthy life to you. Bye-bye.